Welcome, everyone. I am Dr. Trisha Hugulay. I am at the University of Colorado in Denver. I'm a pediatric and adolescent gynecologist and have specific interest and expertise in heavy menstrual bleeding and blood disorders. So I will be moderating this talk and very excited to have you all with us today to talk about screening for a bleeding disorder with our guest speaker, Dr. Nancy Sokkary. So a few housekeeping items. Please, as you join us, do not forget to introduce yourself in the chat, who you are, where you're from. We want to hear from you, and we're really looking for everybody to engage today. So love to see you on the video if you can. Totally understanding we're all busy, so if you need to take moments with your video off, absolutely please do so, but would love to have you on and engaged as much as possible. So a few other housekeeping items. So really important for you to know that it's important, of course, as Project ECHO, in compliance with the accredited continuing education medical education society, that all of our speakers and planners have disclosed any relevant financial relationships they have within eligible companies. And for our staff with the Hemophilia Federation of America, myself and our guest speakers, you can see here any disclosures that they have, which have all been mitigated ahead of these talks to make sure that there's no conflicts of interest. Also important to know, please do not forget to sign in. You can use this QR code here. This is important to have you officially fully registered and also so that you can get your CME information. There will be a post-session evaluation as well that you're also required to do in order to get your CME credit, which you can get 1 full credit for attending the session today. So please take a moment if you can right now to officially sign in. And with that, I am pleased today to introduce our guest speaker, Dr. Nancy Sokkary, who I know well and collaborate with a lot. Dr. Nancy Sokkary is a fellowship-trained pediatric and adolescent gynecologist. She currently is the director of pediatric and adolescent gynecology at Emory University School of Medicine and Children's Healthcare of Atlanta. She has served as the chair for the North American Society for Pediatric and Adolescent Gynecology at the 2022 Annual Clinical and Research Meeting, and she continues to be a very active member of their society, currently in the Education Committee, as well as the Anti-Racism Task Force. Dr. Sokkary has also served on the American College of Obstetrics and Gynecology's Adolescent Committee and is currently serving on the Clinical Consensus Committee, so is very actively involved in building a lot of the educational content, including some of the topics we're talking about today. Dr. Sokkary is actively developing documents currently for the Foundation for Women and Girls with Blood Disorders, in particular around gender-inclusive hormonal therapy guidelines. So welcome, Dr. Sokkary.
Thank you, Trisha, for getting everybody here and organized in that introduction. These are the learning objectives for what I'm going to be going over for about the next 15, maybe 20 minutes, and then we'll do a little case at the end. So we want to recognize and identify the common signs and symptoms that raise the index of suspicion of an inherited bleeding disorder in women. Learn to share information with patients regarding when bleeding may be considered abnormal and warrants further investigation. Identify and locate resources and tools to screen for bleeding disorders. Recall the course of action to take when inherited bleeding disorder is suspected. And you guys will do a deeper dive into that topic, I think, with your next ECHO series when you talk about the actual testing for bleeding disorders. And then incorporate knowledge gained from the ECHO into practice. We'll be doing a case presentation at the end. So this is a really important issue. I think most people that signed up for it probably already recognize that, but bleeding disorders are not uncommon. They are underdiagnosed. So there's an average of 16 years between the onset of symptoms and the diagnosis of a bleeding disorder, specifically von Willebrand's disease. There's huge impacts that lack of or a delay in diagnosis lead to. There's lack of anticipatory guidance, lack of preparation for surgery, pregnancy, or trauma. So the younger we can diagnose people, the more we would be able to intervene. So, menstrual life of heavy bleeding and anemia, if we can intervene earlier, we can help avoid anemia, help avoid transfusions. If there's trauma, surgery, or delivery needed, and we know about a bleeding disorder ahead of time, we're able to do prophylactic measures to avoid bleeding emergency. So we're going to talk a little bit about normal, and then we'll dive more into abnormal or heavy menstrual bleeding. This is from the committee opinion on menstruation in girls and adolescents using the menstrual cycle as a vital sign. So the average age of menarche is between 12 and 13, or 2 to 3 years after breast development. And 98% of girls reach menarche by the age of 15. Now, it can be irregular for often 2 to 3, but up to 6 years after menarche. The average cycle length is 21 to 45 days. So either 2 to 5 weeks between bleeding episodes, 7 days or less of bleeding, and 3 to 6 pads or tampons per day. So heavy menstrual bleeding subjectively is excessive menstrual blood loss that interferes with physical, emotional, social, or material quality of life. From an objective perspective, we've tried to get some measurements, and it is defined objectively as greater than 80 milliliters of blood loss, which of course none of your patients are going to tell you they're milliliters of blood loss. But I will say that with more and more alternative menstrual products, so things like period panties or things, and different like Diva cups and menstrual cups, they actually include, if you just Google them, they'll tell you the milliliters of blood loss that they contain. So for example, if somebody uses 2 Diva cups a day and it's filled, then you can just Google whatever size Diva cup they use, and it actually will tell you the milliliters of blood loss. So we're closer to getting milliliters of blood loss now than we ever were before. But most people are still using pads or tampons. So we would say greater than 7 days of bleeding and greater than 7 pads or tampons per day. Utilizing greater than 1 pad per hour, but for multiple hours and multiple days during the menstrual cycle. Repetitive passage of clots, and then flooding or doubling up. This is from Hamida Farid and Dr. Dietrich's publication in JPAG of the differential diagnosis of heavy menstrual bleeding in adolescents. And we're going to spend a little bit of time on this and the differential diagnosis as defined by the American College of Obstetrics and Gynecology, because part of diagnosing a bleeding disorder is ruling out other causes. So you guys can see right here, endocrine, the way they broke it down in terms of the diagnoses include endocrine and ovulatory bleeding for adolescents and for women approaching menopause. This is going to be the most common reason for heavy and irregular menstrual bleeding. But we certainly see PCOS frequently. This can be a presenting symptom for thyroid disease as well. Bleeding disorders, we're going to take a deeper dive into, so I'll come back to that. Pregnancy and infection tend to be more associated with an isolated or more acute heavy menstrual bleeding event, not somebody that has a long history of cyclic menstrual bleeding. But you can see it in spontaneous abortion, miscarriage, gestational trophoblastic disease, untreated cervicitis, and endometritis. I actually think this was supposed to be endometritis, not adenomyosis, can also result in increased bleeding. And we'll come back to the uterine structural differential diagnosis when we go into ACOG a little bit more. Medications we'll kind of talk about throughout the presentation today, but obviously anticoagulants. So patients that have thrombophilia, patients that have maybe cancer or an acute history of blood clots. We have more and more patients that are having to take long-term or short-term anticoagulants, and that's certainly associated with heavy menstrual bleeding. Also, there's different types of contraception that can be associated with either short or long-term heavy or irregular menstrual bleeding. And then for trauma and foreign body, again, this is more commonly seen when there is a acute heavy menstrual bleeding, or sorry, heavy bleeding episode rather than one that's cyclic and chronic. So abnormal uterine bleeding, defined as heavy menstrual bleeding or intramenstrual bleeding by the American College of Obstetrics and Gynecology, is broken down into structural causes and non-structural causes with an acronym we call POM-CON. So for adult patients, we're going to see the structural causes far more frequently. So polyps, adenomyosis, leiomyoma, malignancy, and hyperplasia. For adolescents and teenagers, younger adults, we're going to see the COINs. So coagulopathy, and that's what we're going to really focus on here today. Ovulatory dysfunction, like I said before, that's the most common cause in patients that are just starting their period or just ending their period. Endometrial, iatrogenic, and not yet classified. So generally speaking, bleeding disorders, specifically von Willebrand's disease, affect 1 to 2% of the population. But if we look at women with heavy menstrual bleeding, you can see that the prevalence of various bleeding disorders is far more frequent. So von Willebrand's disease, somewhere between 5 and 20%, overall estimate about 13%. These are really large ranges when we talk about platelet dysfunction, factor VIII deficiency, hemophilia carriers, and rare factor deficiencies. And there's two reasons for this. It depends on where the study is done. So if the study is done in a primary care setting, the likelihood of somebody having a bleeding disorder is going to be a little bit lower than in the patient population that has been referred to a hemophilia treatment center, for example, or somebody that is like admitted to the hospital for a hemoglobin of 5, you're going to see a little higher rate of bleeding disorders in that patient population. The other reason is because they're imperfect tests for diagnosing bleeding disorders, and you guys are going to, I think, hear a lot more about that in coming echo presentations during this series. The largest prospective trial done to date was by Zia and her team, and they found, now this is at a referral center, so this is a pediatric hematologist, and they found in their patient population that bleeding disorders among adolescents with heavy menstrual bleeding had a rate of bleeding disorders of 33%. So 33% of adolescent females that presented to a pediatric hematology center went on to be diagnosed with a bleeding disorder. The most common bleeding disorder that was diagnosed was low von Willebrand's factor, or von Willebrand's disease, and that was in 80% of the patients. It should be noted that now low von Willebrand's factor with bleeding symptoms is just considered von Willebrand's disease. They found risk factors to be a younger age at first bleeding event, and so that makes sense. So if you have a really heavy episodes of bleeding from the time of menarche, the likelihood that you have a bleeding disorder is going to be higher. And then Hispanic race, and they conjectured or postulated that that has more to do with the decrease von Willebrand seen among Black and white populations. So what we're going to take a really deep dive in here today is who warrants further evaluation. And that really stems from taking a really, really thorough history. So first of all, like we talked about before, the bleeding pattern. So how often do you bleed? How long do you bleed for? And like how many days? And how many pads or tampons are you using in a day? Are you passing any large clots? Is there a lot of flooding? If you don't have a hemoglobin in front of you, then assessing for symptoms of anemia. Sexual and reproductive history is going to help twofold. So one, it's going to evaluate, could the heavy bleeding be a result of some type of infection, pregnancy, or even like a contraceptive method? Additionally, it may help you when you go on to talk about treatment modalities and what should be considered. Associated symptoms, again, ruling out other things like, is this actually coming for the bowel or bladder? I think that's pretty unlikely, certainly in the adult population. Even in adolescents, they can usually tell which hole the blood is coming from. Vaginal discharge and odor, again, assessing for other causes of vaginal or uterine bleeding. Associated symptoms is really important, especially because of the frequency with which we see things like PCOS. So looking for things like acne, hirsutism, like extra hair growth, that leathery skin, acanthosis nigricans, hyperprolactinemia. So this can present with nipple discharge, headache, and vision changes. As well as hypothalamic dysfunction and adrenal disorders. Again, you can see more androgenizing symptoms. Chronic medical illnesses. So obviously, if they have a known bleeding disorder, but also lupus or other connective tissue diseases, and then liver and renal disease will often result in inherent or intrinsic problem with clotting. And so we can often see heavier bleeding in that patient population. Cardiovascular disease will often warrant medication that could result in heavier bleeding like aspirin, but also again, when we're talking about treatment options, this is something that you want to keep in mind. Medications like we talked about before, things like Depo, when you first start them or have an IUD placed, you can see heavier, more regular bleeding. We know with the norgestrel implant or the rod or Nexplanon that you can see not necessarily heavy bleeding, but certainly prolonged bleeding. And like I mentioned before, more and more patients on anticoagulants, that's going to result in heavy menstrual bleeding. And then a family history of a bleeding disorder, obviously, but also any thrombophilias that would guide treatment options for the patient. So when we're talking about bleeding symptoms specifically, that would be red flags or alarming for somebody having an underlying bleeding disorder. I think we've beat the idea of prolonged bleeding with trivial wounds, heavy prolonged recurrent bleeding after surgery or dental procedures, bruising with minimal trauma, nosebleeds that are long, so greater than 10 minutes, and frequent, greater than once or twice a month, unexplained bleeding from the GI tract, anemia requiring iron therapy or certainly transfusion, heavy menstrual bleeding, which I think that we've covered that in depth, and then a family history of bleeding disorders, obviously, or a postpartum hemorrhage. So that's a lot to remember. There's a lot of red flags. So there have been multiple validated bleeding assessment tools. The bleeding assessment tools are a way of evaluating patients that present with heavy menstrual bleeding to see if they warrant further evaluation with a more simple, straightforward questionnaire. So it's recommended for patients presenting to a primary care setting to decide if specific blood tests are recommended. So if they're presenting to a gynecologist or women's health specialist, their primary care doctor, pediatrician, it is suggested against using this for patients relying to a hematologist. We feel like people that are referred to a hematologist, they've already met the criteria for suspicion for a bleeding disorder, so we wouldn't use it in that setting. The International Society for Thrombosis and Hemostasis has a really involved bleeding assessment tool. It's 14 variables. Each score is 0 to 4, and a total score of greater than 5 is considered abnormal in females. However, the sensitivity and specificity of this particular bleeding assessment tool varies greatly depending on the population, if we're talking about adolescents versus adults and males versus females. So Philip et al. Put together another bleeding assessment tool that was based on something like a 14 page questionnaire, and they went through the way that women with and without bleeding disorders that had heavy menstrual bleeding presented, and they found 82% sensitivity for bleeding disorders if the patient reported that during the menses they bled greater than or equal to 7 days and had flooding or impairment of daily activities with most menses, in addition to either severe anemia, family history of diagnosed bleeding disorder, or a history of excessive bleeding with tooth extraction, delivery, miscarriage, or surgery. Based on that, ACOG recommends for adult women who have heavy menstrual bleeding since menarche and either a postpartum hemorrhage, surgery-related bleeding, or bleeding associated with dental work, or if they have 2 or more of these symptoms at the bottom, so bruising, again, nosebleeds, frequent gum bleed, or family history, would go on to get a bleeding disorder. For adolescents, it's a little bit more straightforward, simply because if you've had heavy menstrual bleeding from, you're an adolescent, you've had heavy menstrual bleeding from menarche, the likelihood that you would go on to be diagnosed with a bleeding disorder is a little bit more likely than in a woman who reports heavy menstrual bleeding, but she's 30. She thinks it's been since menarche, but there's a chance that she maybe had normal periods for a good portion of her life, and then her periods changed. that may be from a different etiology. So for adolescents specifically, they recommend doing a bleeding disorder assessment in terms of a lab workup if one of the following is true. The duration of menses is greater than or equal to 7 days, and they report flooding or bleeding through a tampon or napkin in 2 hours or less with most periods, a history of treatment for anemia, a family history of a diagnosed bleeding disorder, or a history of excessive bleeding with tooth extraction, delivery, miscarriage, or surgery. Some additional resources and tools that you can use are phone apps. I find phone apps incredibly helpful. Instead of asking somebody to remember exactly when their period was, how long they bled for, what the interval was, if they just keep track of it on a phone app, and there are several out there, it's whichever works best for your patient. It's much easier sometimes to actually just look at their phone and what they've recorded during the visit, and it tends to be a little bit more objective. The other thing that's utilized more so for research, but certainly some people use it in the clinical setting as well, is the pictorial bleeding assessment chart score. And I have an example of one over here on this side of the screen. A score of greater than 100 would be consistent with 80 milliliters of blood loss or more, so defined as heavy menstrual bleeding. It's most reliant when it's done prospectively, but certainly some people do use it retrospectively. You can see here, these are the days that they're bleeding. So the first day that they're bleeding through like the 8th day that they're bleeding. And then it shows both pads and tampons. And then you get a score based on how saturated the pad or tampon was. And then you count up that total score. So for example, on the first day, this individual just used 2 very minimally soaked pads, so she got 2 points. The next day was really, really heavy, and so she used 5 totally soaked heavy pads and tampons. So each of these notches would be 20 points, 10 points here. Then you would get additional 5 points for clotting and flooding, large clots or flooding. So for this day, it was 135 points. And so you would total that up for the 6 days that this individual bled, and it looks like it was definitely consistent with heavy menstrual bleeding. So after you've evaluated the patient, decided that they do warrant further testing, your future echo series is going to get into what laboratory testing should actually be done.